Guys, welcome to my YouTube channel Study with Dr. Brainiac. Today we will discuss endoscopy in gynecology from the textbook SAW. Sixteenth edition. Okay. So let's begin with our chapter Endoscopy in Gynecology. Chapter outline: we will discuss 4 surgery and one also extragenital surgery also included. 5 surgery: laparoscopy, hysteroscopy, salpingoscopy, phalloscopy, colposcopy, extragenital endoscopy. Okay, so let's begin with our chapter. Endoscope are telescopes designed to view the interior body space orbits. Although attempts at endoscopy date back to over 100 years, the potential of this method as diagnostic therapeutic tools were appreciated and came to the forefront only in the last 3 decades. When used appropriately, endoscopic surgery offers the advantage of more accurate diagnosis, less invasive, reduced pain, faster recovery, shortened hospital stay or day care. Advance in instrumentation and technique now enable the endoscopist to accomplish several operative procedures hitherto performed only by open surgery, including cancer surgery. Some of the advances are harmonic scalpel, suture material, and laser. Minimal invasive surgery implies avoiding an abdominal scar, minimal handling of pelvic and abdominal organ, less pain, thereby fast recovery. And advantages of laparoscopy. One important topic for university exam: laparoscopy. Advantages of laparoscopy: lesser pain, few analgesic to be used, short hospital stay, quick return to daily work, no scar hernia, no incisional hernia, good cosmetic value, less pelvic adhesion. Disadvantages: long procedure, more anesthesia, expensive expertise required. Okay. Laparoscopy. Laparoscopy was developed by the 1970s, and operative laparoscopy has started gaining ground in the last 2 decades. Advances in technology led to the development of high-resolution cameras. Video laparoscopy, the development of safe instruments permitting the use of electrical and laser energy, and harmonic scalpel for cutting and cauterizing tissue for achieving homeostasis. Its role in the management of infertility stands undisputed. So also the benefit of laparoscopy over laparotomy of being minimal invasive and having lower incidence of adhesion, formation and infection render endoscopy to be an attractive alternative procedure in many gynecological diseases. Despite of these advantages, there are potential limitations. For example, exposure to the operative field may be reduced, manipulation of the pelvic viscera often restricted, and to tissue apposition during suturing not as accurate. Moreover, the field of tissue experienced by the surgeon during open surgery lacks during endoscopic surgery. The endoscopic surgeon in the making has to go through supervised training and acquire the skill over a period of time. There is a learning curve during which the endoscopist in training understand the limitations of the procedure and know when to stop. Thereafter, the incidence of complication during endoscopy begins to decline and progressively more complex procedures can be successfully undertaken. Laparoscope. Look at the laparoscope image. Following types of laparoscopes are there and accompanying instruments. Laparoscope with angle eyepiece. You can look at this angle, making an angle with the horizontal line. So we can remember that this trick. Laparoscope with angle eyepiece. Laparoscope with parallel eyepiece. Okay, this line going parallel with the main part. And biopsy forceps, seam forceps, scissor, large grafting forceps, suction manipulator and syringe, palmar biopsy forceps, okay, bipolar forceps. These are the forceps, these are the instruments used in laparoscopy along with the laparoscope images. We have discussed. Okay, now come to the indications of the laparoscopy. The laparoscope has emerged as an invaluable tool in the armamentarium of the gynecologist, both for diagnostic and therapeutic uses. Diagnostic laparoscopy. The common indication for diagnostic laparoscopy include, remember this table, very important. Diagnostic: infertility, tubal patency, adhesion, pathology, uterine disease, ovulation, PCOD, ovary PCOD, size, volumes, adhesion, pelvic endometriosis, chronic pelvic pain, ovarian malignancy, tumor nature, benign, malignant, extent, staging, carcinoma, second look surgery, uterus malformation, absent uterus, septate, fibroid, adenomyosis for fluorescence during surgery, tubal infertility, PID, ectopic pregnancy, pelvic tuberculosis, prior to tuboplasty to study the feasibility. Therapeutic indications: pelvic adhesiolysis, ablation of endometriosis, PCOD, drilling, ovarian cystectomy, ovariotomy, surgery, lymphadenectomy in cancer cervix uterus, ovary myomectomy, myelinolysis, gift in infertility, septate uterus, ectopic pregnancy, tuboplasty, LAVH, hysterectomy, removal of hydrosalpinx and biosalpinx, vault prolapse, stress incontinence, Luna, full form is laparoscope, uterosacral nerve ablation, used in dysamenorrhea. Okay, so diagnostic laparoscopy. The common indication of lapro include the following: infertility and tubal disease. Laparoscopy is indicated in Salpingoscopy reveals abnormal and ambiguous findings. Laparoscopy can reveal peritubal adhesion not detectable by hysterosalpingography. Chromoperturbation using methylene blue dye is a part of diagnostic laparoscopy for infertility evaluation. To determine tubal patency, a band is recognized extending from the right tube to the undersurface of the liver in pelvic inflammatory disease caused by gonococcal and chlamydial infection. This goes by the name Fish-Huggerty syndrome. The relationship between the ovary and the ovarian fimbria can be studied in infertility. The laparoscopy decides the best treatment between tuboplasty and IVF. Salpingoscopy through laparoscopy studies the ampullary portion of the tube and extent of the tubal diameter. Endometriosis: in about 20% of the patients with infertility, endometriosis is present without any symptoms. It remains undetected until demonstrated at laparoscopy. Chronic pelvic pain: in patients complaining of chronic pelvic pain not responding to usual therapeutic measure, laparoscopy is indicated. Often unsuspected pathology is brought to the light of such as adhesion, cyst, chronic PID, tubal to Salping's endometriosis, pelvic congestion, window tear in the broad ligaments, and varicosity of the Pempiniform plexus of veins. Even a negative finding is valuable to reassure a patient that there is no pelvic pathology. Conscious pain mapping helps to identify the organ which causes pain. Ovarian disorder, most reproductive endocrine disorder of the ovary do not need diagnostic laparoscopy, ovarian surgery or biopsy. Ultrasonography and blood hormonal assay usually suffice in arriving at diagnosis. However, in case of polycystic ovarian disease (PCOD), laparoscopy is useful to confirm the diagnosis and to further investigate the patient for other causes of infertility. The operation of ovarian drilling is performed to improve the result of ovulation induction therapy. Ovarian cyst extent and spread of malignant tumor can be assessed by laparoscopy. Second look surgery is now replaced mostly by ultrasound, MRI, and tissue marker. Suspected adnexal masses. Ultrasonography, CT scan, MRI help in detecting adnexal masses and establish their site of origin. However, it is not possible to identify a pedunculated fibroid from a solid ovarian tumor, and laparoscopy is necessary. Laparoscopy helps to distinguish a pelvic mass as uterine in origin, commonly a fibromyoma, from an ovarian mass. An asymptomatic fibroid may require observation, whereas an ovarian solid mass needs prompt surgical removal. Suspected ectopic pregnancy. In a patient with abdominal pain, irregular menstruation, and a positive pregnancy test, a laparoscope can detect an ectopic pregnancy even before it has ruptured and enable conservative surgery, thereby preserving her future reproductive potential. Pelvic inflammatory disease. In PID, the diagnosis can be confirmed on laparoscopy. Peritoneal fluid or pus can be obtained for culture, and other causes such as acute appendicitis and pelvic tuberculosis considered in the differential diagnosis and can be ruled out with certainty. Ovarian malignancy. In advanced ovarian malignancy, a laparoscopy is useful in staging with disease, in obtaining a biopsy from the affected tissue which confirms the type of tumor, and have the oncologist to select chemotherapy or radiotherapy as an alternative therapy in an inoperable cases. Ascites. In ascites, laparoscopy helps to obtain ascitic fluid for cytology and biochemical analysis. It also helps to determine the cause of ascites as attributable to tumor, tuberculosis, or hepatic cirrhosis. A biopsy from the tumor establishes the diagnosis. Ultrasonic guided aspiration of fluid and biopsy is, however, a simpler procedure as compared to laparoscopy. Tuberculosis. Genital tuberculosis accounts for 5% of patients of unexplained infertility in our country. The fallopian tube is the most commonly affected site. Presence of tubercles on the serosa, multiple constriction, thick rigid tube, presence of voiline, string adhesion, and tobacco pouch. Appearance of the terminal part of the tubes should arouse suspicion. Presence of tubercles on the bowel serosa or peritoneal surface can be biopsied to arrive at the diagnosis. Uterine abnormality. Laparoscopy reveals uterine abnormality. Mullerian anomalies such as absent uterus, in case of Rokitansky-Hauser syndrome, bicornuate uterus septate, or presence of rudimentary horn. Testicular feminizing syndrome. Laparoscopy can distinguish between a septate uterus and bicornuate uterus. An enlarged uterus due to fibromyoma or adenomyoma can be diagnosed. Addition to the uterus and its retrovert fixity. Uterine perforation during MTP and DNC can be confirmed or refuted laparoscopically, and decision made regarding the need for laparotomy. Inspection of the pouch of Douglas. This can be inspected. Often endometriosis is present at the site, so also addition to the rectum present. This can be a site of pelvic abscess and ovarian metastasis. Operative laparoscopy. Minimal invasive surgery is replacing conventional surgery as the procedure of choice in selective gynecological surgery. General indication. Pelvic condition. The These additions are often post-inflammatory, post-surgical, or endometric in nature. Laparoscopic adhesiolysis restores the anatomy of pelvic organ, their mobility, and relieves pain and discomfort arising out of the binding of the organ by adhesion. Pelvic endometriosis may affect many pelvic structures such as the ovary, tube, uterosacral ligaments, serous surface of the uterus, pelvic peritoneum, and the pouch of Douglas, and also the rectum, bladder, ureter. Adhesiolysis is done by the ablation with the cautery laser surgical excision of the lesion within the limit of safety and relief symptom. Adhesiolysis is especially required in tubal infertility to restore the patency and mobility of the fallopian tube and spermia. Ovary. The various minimal invasive surgery on ovaries are PCOD. The medical hormonal therapy cures PCOD in many women. Those who fail to respond, and in infertile women, laparoscopy puncture of the cyst by cautery or laser improve the response to the hormone ovulation stimulation ablation, avoid hyperstimulation syndrome, and improve the fertility rate to 60 to 70%. However, because of possible subsequent adhesion formation and thereby impaired tubal fertility, women are advised to try conception in the first year of ovarian puncture. It is strongly recommended that no more than 4 cysts should be punctured in each ovary. More puncture may increase the ovarian adhesion and ovarian destruction, leading to premature menopause later. Ovarian cyst. A simple cyst less than 5 cm is usually a functional cyst, and it disappears in 3 months time and need only observation. A large benign cyst can be aspirated laparoscopically and fluorescent for cytology. The cyst wall is then peeled off by aqueous suction and tissue sent for histopathology. Chocolate cyst. The chocolate cyst is inside the content aspirated and the cyst wall cauterized or peeled off. Pelvic endometriosis is also ablated. Gift. Gamete interfallopian transfer is assisted reproduction is performed laparoscopically by placing 2 ova and 50,000 sperm at each ampullary portion in an infertile woman with patient tube. Second look surgery laparoscopy is undertaken following primary surgery and a complete course of chemotherapy for ovarian cancer. Before deciding if further chemotherapy or excision of residual tumor is required, lately, however, tissue markers are relied upon and this procedure is avoided. Pelvic lymphadenous adenectomy is now performed laparoscopically in early cancer cervix and followed by vaginal hysterectomy or trachelectomy. This inflicts less surgical morbidity and allows quicker recovery, especially in an obese woman. Expert oncologists are now performing Verthium hysterectomy laparoscopically safely with equally good result. The uterus operative procedure on the uterus include myomectomy, laparoscopically assisted vaginal hysterectomy, excision of rudimentary horn, Verthium's radical abdominal hysterectomy for cancer cervix. Myomectomy is best planned for a young woman. Ideally, it is rewarding in cases with not more than 4 fibroids, preferably subserous, and of moderate size not exceeding about 5 cm in size. After enucleating the myomas from their pads, the cavity is obliterated with interrupted opposing endosutures to achieve hemostasis and prevent adhesion formation. Large fibroid may be removed or morcellation or through a small suprapubic incision. Small myomas can be removed piecemeal after threading or by the vaginal route through the posterior colpotomy incision. LAVH laparoscopic assisted vaginal hysterectomy is performed in women in need of hysterectomy for benign condition myoma, adenomyoma, menorrhagia, abnormal uterine bleeding, and in situ cancer of cervix in whom there is no descent of the uterus to facilitate vaginal surgery, and in women over the age of 45 years in whom concomitant removal of the ovaries is desired. The purpose of LAVH is to convert an abdominal hysterectomy to vaginal hysterectomy or a difficult vaginal hysterectomy to an easy surgery. realizing that the areas carry a higher morbidity in terms of prolonged anesthesia and restricted viewing. Many laparoscopists now perform vaginal hysterectomy even on undescended uterus and are able to remove both the ovary from below as well. Other uterine surgery done under under laparoscopic guidance are excision of uterine septum and synechia in Asherman syndrome. A rudimentary non-communicating horn may be the site of hematomatra, ectopic pregnancy, or torsion. Laparoscopic removal is feasible in such cases. Oncologists now perform vaginal hysterectomy laparoscopically, radical abdominal hysterectomy, and bilateral extraperitoneal dissection and excision of the iliac and pelvic lymph node for the cancer of the cervix. For fallopian tube, most common operation performed on the tube is sterilization. For family planning, the tubal blockage is achieved through occlusion is fallopian or Felsi's clip. An early unruptured ectopic pregnancy can be treated effectively laparoscopically. The surgeon may attempt milking out of the gestational sac, particularly so if it is close to the fibula, and an ampullary ectopic pregnancy can be treated by linear salpingostomy and inoculating the tubal gestational sac. An early unruptured ectopic pregnancy can be treated by the local injection of the methotrexate into the gestational sac. All these procedures are conservative measures aimed at preventing the woman's reproductive potential. Hydrosalpinx of the tube can be treated by the lateral salpingostomy and fibroplasty with eversion of the inverted fimbriae by fashioning a cuff. In block tube, segmental resection and anastomosis have been unsuccessfully performed laparoscopically. Hydrosalpinx is also removed prior to IVF to improve the pregnancy rate. Other indications: among the other operative procedures are complex laparoscopically, the following deserve to be noted: genital prolapse, extraurinary incontinence, pelvic floor repair, dysmenorrhea. Technique of laparoscopy. Laparoscopy has become a safe, minimal invasive surgery. Therefore, it is employed more liberally than before, both for diagnostic and for certain therapeutic procedures. However, bearing in mind that a rare but a serious complication may develop during therapeutic procedures such as myomectomy, hysterectomy, ablation, endometriosis, certain preoperative preparation are required. These are fibroid. It is desirable to shrink the huge fiber to reduce bleeding and make it easy to perform myomectomy. This is done by gonadotropin releasing hormone injection administered monthly for 3 months. Bowel preparation and intestinal antibiotic Metrogyl are safe precaution in case of bowel injury occur. Bladder should remain empty throughout the procedure using catheter. Systemic antibiotics should be started a day before surgery. Signature for open surgery should be obtained in the case of complication or inability to complete the procedure laparoscopically. Procedure, where the diagnostic procedure may be carried out under sedation and local anesthesia, the therapeutic procedure always requires general anesthesia because of prolonged time taken and intra-abdominal manipulation required. Position is simultotomy and slight Trendelenburg position. Pneumoperitoneum is created with the ferrous needle using carbon dioxide gas through small infraumbilical incision. Air and nitrous oxide should not be employed because of the risk of air embolism in the former and combustion with N2O if electrocautery is used. The proper pneumoperitoneum is confirmed by noting the uniform distension of the abdomen and palm attached, which consists of the injecting 5 ml of the saline through varus needle. Failure to aspirate saline indicates proper replacement of the needle. Continuous flow of CO2 is maintained at the rate of 100 ml per minute and pressure at the 15 to 25 mmHg. Trocar and laparoscope insertion follow through the incision, same skin incision. Under fabric optical illumination, the pelvic organs are inspected and feasibility of the procedure under consideration confirmed. Bipolar cautery is safer than monopolar cautery, as it does not spread the burn to the surrounding structure. The laser is even safer and does not form post-operative adhesion, but is expensive. Lately, harmonic scalpel is available and though very expensive, is very safe and cuts the tissue well. Additional portal and instruments are used in therapeutic procedures. Suction and irrigation are also provided to clear the blood and fluid from the abdominal cavity. At the end of procedure, after making a sure hemostasis is secured and no gut injury has occurred, gas is expelled from the peritoneal cavity and the skin cut sutured. During the procedure, the uterus is manipulated in different directions by using uterine manipulator inserted cervically before the start of the surgery. Complications 0.5 to 1% are observed in minor procedure, but the incidence of high as 5 to 15% are reported with major procedure. Death is reported in 0.08 is to 10,000 cases. Major complications are as follows: cardiopulmonary arrest, gas embolism, CO2 cause acidosis, arrhythmia, cardiac arrest, hemorrhage, cautery burns to viscera, various viscera, sepsis, injury to bowel, insert and blood vessel, bladder ureter with the sharp instrument, and burn injury, failure to complete the procedure. Cardiopulmonary arrest is an anesthetic complication. Anesthetic complication. Embolism occur with the use of air but CO2 and accidental insertion of various needle into the blood can also cause embolism. This mishap is avoidable if pneumoperitoneum is checked by permanent hemorrhage. Injury to the epigastric vessels occur during insertion of the various needle and trocar. Injury to the aorta, inferior vena cava, iliac vessel, and mesenteric vessel mainly occur with sharp instruments such as trocar. Prolonged surgery during myomectomy can also cause loss of blood. Careful insertion of the trocar can avoid the injury. Uncontrolled hemorrhage require laparotomy. Cautery burns. Accidental burn to the surrounding structure occur with the unipolar cautery and sometimes with laser. The injury may go unnoticed during surgery and may manifest clinically as peritonitis for 24 hours or even more. The abdominal distension and vomiting are then the first indication of gut injury and peritonitis. The bowel injury requires laparotomy, resection of the bowel, and end-to-end anastomosis. Sepsis is avoided by preoperative anastomy, antibiotic, and aseptic precaution. Traumatic injury to the viscera and urethra occur with sharp instruments, bladder, ureter, and intestine or bone. Other complications. The other complications include surgical emphysema and hematoma. Post-operative peritoneal adhesion occur less commonly with laparoscopy than laparotomy because the viscera are not handled and not exposed to the air dryness. As in open surgery, hernia at the site of porta with omentum protrusion rarely occur. The uterine perforation with the uterine manipulator does not normally require laparotomy. Metastatic cancer has been reported at the porta. Emergency therapeutic procedure done laparoscopic before torsion and hemorrhage of ovarian cyst or rupture of endometrioma carry greater risk than planned surgery, since pre-operative preparation may not be adequate. Failed procedure due to adhesion, extensive pelvic lesion, and controlled hemorrhage. Laparoscopic procedure need to be abandoned and converted to laparotomy. The prior signature of this effect avoid medical legal problems. Contraindications to laparoscopy. Extreme obesity makes the laparoscopy procedure and pneumoperitoneum difficult to, if not impossible. Extreme obesity. Possible alternatively, pneumoperitoneum can be created through posterior colpocentesis. Cardiac and respiratory disease contraindicate Trendelenburg position, and CO2 peritoneum. Diaphragmatic hernia preclude Trendelenburg position. Umbilical hernia. The trocar can injure the bowel if the latter is adherent to the hernial sac. Previous abdominal scar also expose the bowel to injury during trocar insertion. Acute pelvic infection can spread during laparoscopy. A large uterus and an abdominal tumor can be injured by the sharp instrument. Advantage of laparoscopy over laparotomy. Avoidance of abdominal scar, bone sepsis, and scar hernia, reduce pain and quick recovery. So, hospital stay, less peritoneal addition post-operatively. Lately, robotic surgery is being attempted. Hysteroscopy. Neck surgery. Hysteroscopy, which was started in first 1869 with Pantaleoni as a mean of inspecting the uterine cavity, is today functioning as an extended gynecological armamentarium in various therapeutic procedures. Despite the initial poor light source and non-availability of standing media, stereoscopy was not abundant, and its improvement developed into an important minimal invasive surgery and has led to resurgence of interest worldwide in recent years. Stereoscope instruments. Look at a stereoscopic view. Stereoscope comprised of rigid 4 mm telescope with Hopkins rod lens optical system having a wide viewing angle of fiber optic illumination cable, camera and television system enabling video study and their therapeutic procedure. The sheath is 5 mm diameter in the center of which the telescope is fitted. The uterine cavity is distended with CO2 at the rate of 70 ml per minute and pressure less than 100 mmHg, or with saline texture has scone or glycine 1.5%. The scope is covered by inner sheath for inflow of distending medium and outer sheath for its outflow. Type of stereoscope. Types. Look at the types. Microstereoscope provide magnification of 30 to 150 times. Contact stereoscope is a diagnostic tool without distending medium. Flexible stereoscopy can be directed to all parts of the uterine cavity and extensive inspection is possible. Technique stereoscopy should be performed in the pre-ovulatory phase when the endometrium is thin and bleeding is likely to occur. In transcervical resection of endometrium, TCRA, shrinkage and endometrium is achieved with progesterone, danazol or GnRH given continuously for 6 to 8 weeks prior to surgery. The diagnostic stereoscopy can be performed under local anesthesia and sedation, but the therapeutic procedure mandates general anesthesia. The cervical dilation is not always required. In a post-menopausal woman, cervical and mesoprostatal vaginal tablet will soften the cervix and cervical dilatation with the metal dilator made atraumatic as and required. The woman is placed in lithotomy position and bimanual examination comes from the position and size of the uterus and also rules out the adnexal mass. The cervix is dilated up to 4 to 5 mm. The stereoscope is connected to the source of distending media. As the distended medium is distended, the cervical canal and uterine cavity, the telescope is progressively advanced to the uterine cavity under direct vision. This precaution avoids perforation. Endocervical and uterine lining are studied. The both uterine mostly identified. Gas inflating machines used in laparoscopy should not be employed in stereoscopy since high pressure of the can cause gas embolism. The stereoscope is provided with a cervical adapter which fits snugly onto the cervix and prevents backflow of uterine distending media. CO2 obscures the vision in presence of blood and cannot be employed in presence of bleeding. Its use is therefore limited only to diagnostic hysteroscopy. 5% of glucose is cheap and mixed with blood. Scone and glycine are used mostly nowadays. Scone 32% dextrose coalesces with blood in globule while the medium remains clear. Normal appearance of endometrium. The appearance of endometrium changes with the phase of menstrual cycle. During follicular phase, the endometrium looks thin and pale, with a smooth surface and minimal vascularization. The glands are not easily seen. At ovulation, the endometrium appears edematous and the glands are seen in the luteal phase. The increased vascularity causes edema and endometrium looks pink with the glands seen. Postmenopausal endometrium is thin, pale in color. The glands are hardly seen even with high magnification. Diagnostic indication: the study of endocervical mucosal lining, panoramic or contact stereoscope allow inspection of endocervical epithelium in dysplasia and carcinoma in situ of the cervix to trace the neoplastic procedure into the endocervix and map the extent of neoplasm. Biopsy can be taken from the suspicious area and the cervical polyp can also be identified and removed. Staging of the cancer of the cervix and endometrium is done by endocervical biopsy. Congenital malformation of the uterus hysteroscopy combined with the laparoscopy confirm whether the uterus is separate or biconate, enable the assessment of the capacity of each horn and also study the depth of thickness of the septum in planning corrective surgery. The presence of the fundus in laparoscopy indicate it is a separate uterus. In a biconate uterus, the fundus is absent. Endometrial tuberculosis. The presence of caseous area ulcer tubercles on the endometrial lining suggests tuberculosis. Selective biopsy are required to confirm the diagnosis accurate as done. As I mentioned, hysteroscopy confirm uterine synchrony type and extent of adhesion. Misplaced IOCD. Although ultrasound can locate a misplaced IOCD, stereoscope determine if it is embedded in the endometrium and allow its safe retrieval under direct view. Endometrial lesion and abnormal uterine bleeding. Endometrial and placental polyps, mucous fiber polyps, endometrial hyperplasia, and carcinoma can be identified hysteroscopic. 5% acetic acid application render abnormal endometrium and aceto-white appearance. Selective biopsy and downward extension of endometrial cancer can be assessed and staged in a suspected case of cancer. It may be prudent to perform contact hysteroscopy, which avoid the risk of peritoneal splash of cancer cell when the standard medium is used. Negative finding for cancer can be very assuring to the woman. Polyp. Endometrial polyp may be single or multiple, less than 1 cm in size, and its appearance is identical to the surrounding endometrium. It is usually sessile, immobile, and is caused by fold of endometrium is hyperplasia. Therefore, the polyp will disappear during follicular phase. On the other hand, a mucous polyp is often bigger than 1 cm, sessile and pedunculate, mobile, permanent. A fibroid polyp is formed permanent and of various size paler than a mucous polyp. Corneal tubal blockage. When salpingoscopy shows blockage of the cornea and of the tube, hysteroscope enable the follow-scope to be inserted into the cornea and studies patency and mucosa. The decision regarding the feasibility of the tubal surgery can then be taken. Cannulation of aderolysis are also possible. Therapeutic indication in therapeutic procedure, cervical dilation up to number 10 may be required to insert the operating channel, and because of prolonged surgery, general anesthesia is necessary. Indication: uterine septum, Asherman syndrome, embedded IUCD, polypectomy, some mucous fibroid, abnormal uterine bleeding, new technique of tubal sterilization, tubal blockage, IVF program, intrafallopian insemination in infertility is practiced by a few. Okay, indication of hysteroscopy is explained. 7.2, table 7.2. Look at this table. Diagnostic endocervical study in suspected endocervical malignancy, pre-invasive cancer and biopsy, uterus malformation, endometrial TVSM and syndrome, misplaced IUCD, menorrhagia, intermenstrual bleeding, submucous fibroid, polyhaloscopy, endometrial polypectomy, submucous fibroid, septic uterus, Asherman syndrome, removal of IUCD, tubal sterilization, ballonoplasty, IVF, interfallopian insemination. Now, contraindication to therapeutic procedure are as follows: genital tract infection, pregnancy, during menstruation, view is obscured and infection rate increases, scarred uterus and enlarged uterus more than 12 weeks, size form relative contraindication. Cervical stenosis can cause cervical tear and uterine perforation. Dysmenorrhea can worsen the following: TCRE, cardiopulmonary disorder, anesthesia, risk, fluid over blood and pulmonary edema. Distension media in stereoscopy. Distension media in stereoscopy. Several distension media are current uses in stereoscopy. The choice of medium depends on the availability of safety, effectiveness, and cost, as well as whether cautery or laser is used. The media in common uses include carbon dioxide gas delivered through the sterofilter at a maximum rate of 70 ml per minute and a pressure less than 100 mmHg. This gives a clear panoramic view of interior of the uterine cavity, but flattens soft pedunculated polyp against the uterine lining as against those seen as a floating object. When liquid media are used, the popular liquid media used in practice include normal saline 5% dextroadenal lactate solution to provide adequate uterine distension. The uterine pressure needs to be 40 to 50 mmHg. More sophisticated pressure systems are available for use during prolonged stereoscopic operative procedures such as myomectomy, septum cutting, or endometrial ablation, where continuous flow of fluid is essential. In the above-mentioned procedure, the use of electrocautery is necessary. In such case, the distension medium must be non-ionic to prevent a spread of electrical energy. Also, medium should not get admixed with the blood, as this would interfere with the proper visualization of the ongoing operative procedure. The distending media in common use are scone and glycine. Scone 1.5% is very thick and sticky, hence immediate after the operation the stereoscope and its sheath must be thoroughly cleaned and with the sheath scrupulously bruised off all traces of the medium. Delay may lead to jamming of the instrument. Scone is a concentrated dextran solution not miscible with blood and good optical quality. It can cause anaphylactic reaction infection. Glycine is absorbed from the uterine cavity and peritoneum. Excess glycine can lead to problem of fluid overload and electrolyte balance disturbance. Hence, it cannot be overemphasized that strict monitoring of the amount of glycine used, its input and output must be accurately documented. Also, a record of electrolyte reading before commencement of surgery at the end of the same must be documented as safety precautions. Contact stereoscopy. This 6 mm contact stereoscope Hamau type can be inserted into the uterine cavity without prior dilatation. On light contact with the endometrial surface, systemic examination of all the uterine walls and the fundus, it enables assessment of normality of the endometrial tissue lining and help to diagnose any early neoplastic change. Complication of stereoscopy. The following complications: anesthesia complication, more with the CO2 used as a distending medium, gas embolism can occur, uterine perforation, organ injury to the bowel and intestine is rare, thermal injury, bleeding can occur, sepsis, embolism with CO2 can be avoided by using the proper instrument, not increasing the flow to more than 70 ml per minute and pressure less than 100 mmHg, avoiding head low position. Also reduce the morbidity when embolism occur. Distending media cause complication in 4% cases. While allowing proper viewing and surgical procedure, the previous distending media can increase the procedure morbidity. Allergic reaction is noted with dextran and glycine, fluid overload, failure to perform therapeutic procedure, rate complication, hematometra following cervical stenosis, unwanted pregnancy following TCRE, cancer, endometrium, infection, dysmenorrhea, amenorrhea, treatment failure, repeat surgery for treatment failure, uterine rupture, salpingoscopy and fluoroscopy. In salpingoscopy, a fine salpingoscope 1 millimeter in diameter is introduced through the fimbrial end of the fallopian tube, while the laparoscope ampullary portion study after distending is lumen with saline. Flattening of mucosa, addition and mucous polyp can be recognized, and feasibility of tuboplasty considered hysteroscopy. Fluoroscopy reveals the tubal pathology of the coronal and intestinal end of the fallopian tube. The risk of these endoscopes are perforation, damage to the tubal mucosa, infection, difficulty in inserting the catheter. Colposcopy. Colposcopy is also important. Short note may be asked. Examiner can ask short note on colposcopy in university exams. Colposcopy, first introduced by Hinselmann in 1927. Okay, indication for colposcopy. Look at the colposcope. Indication: abnormal pap smear of the cervix, even persisting CIN1, especially those with positive HPV infection, should be screened because as much as 50% of persistent CIN1 and CI and second and third on colposcopy on subsequent histology. Abnormal area on the vagina and preoperative assessment in early stage of cancer cervix. Abnormal vulval area. Locate the abnormal area on biopsy. Therapeutic indication: precise conservative treatment with cautery and laser and cone biopsy can be performed in CIN. These are under colposcopic guidance using micromanipulator which delineate the area and destroy the entire lesion. Depth of the reduction of the 4 to 5 mm is inadequate in CIN lesion. Depth up to 1 cm may sometimes be required. Lifelong follow-up of conservative treatment for pre-invasive cancer cervix. Technique: colposcopy is best performed during proliferative phase of optimal finding, though it can be performed any day of the cycle, but not during menstruation. The cervix is moist with mucus and the external os slightly petulous in the proliferative phase and expose the scamocolumnar junction adequately. The patient is placed in lithotomy position, same as the hysteroscopy. The cervix is exposed with the bivalve speculum and the colposcope focused on the external os at the distance of 20 cm. For a general view of cervix, the lower magnification is used. The cervix is gently swabbed and cleaned with a saline to remove the mucus, taking care not to provoke bleeding. The scamocolumnar junction is brought into view and inspected before after applying 3 to 5% aqueous acetic acid solution. 3% of acetic acid is applied to a thin epithelium, but it takes more time to turn aceto white. Acetic acid precipitated protein abnormal epithelium appears white. Wait for at least 1 minute for the color change. Viewing to aceto white area after interposing a green light filter permit a more clear assessment of the vascular arteries. Finally, the cervix is painted with the Schiller's iodine, which differentiates the darker glycogen-laden cells from the paler glycogen-free cells, which are abnormal. In postmenopausal women, it is desirable to administer estrogen daily for 1 to 2 weeks to improve colposcopic finding. and allow squamous junction to poke out of external or vaginal mesoprostol 3 hours before colposcopy can also dilate the cervix canal or endocervical visualization. Transformation of columnar epithelium to squamous cell is known as metaplasia, which occur at transformation zone, also known as squamocolumnar junction. Metaplasia is benign at the typical atypical metaplasia developing under the adverse environment such as pH, hormonal influence, virus mutagen become precursor of cancer cervix. Colposcopic finding. Interpretation of finding are based on the following: response to acetic acid, response to local hydrogen, the surface and contour and margins, punctation, mosaic, intercapillary distance, atypical vessel. Invasive, more high-grade squamous intraepithelial lesion, comma-shaped and corkscrew-shaped vessel. Colposcopic view of transformation zone. Look at this. White area also appear in inflammation, SPV infection, metaplasia during regeneration tissue. Indication for colposcopy: diagnostic and therapeutic. Abnormal pap smear, cervical lesion, vaginal lesion, vulval lesion, follow-up of ablation. Okay, therapeutic CIN, second, third, ablative therapy, conization. Colposcopic examination is considered. Oh, God. 1 minute. Colposcopic examination is considered satisfactory when the entire squamocolumnar junction is visible and the lower portion of the endocervical columnar epithelium is seen. Normal columnar epithelium look like red grape-like structure with furrow. Squamous epithelium looks homogeneous gray. Abnormal finding: abnormal area turns to white with acetic acid. The faster this appears and longer it lasts, the higher is the grade of lesion. White area shows a sharp margin and mosaic pattern with a regular mosaic formed by the vessel running parallel to the surface. The vessel running perpendicular to the surface shows a irregular large punctate red spot. The white area is irregular with a raised papilla. Invasive cancer shows comma-shaped or corkscrew-shaped vessel with a wide irregular mosaic. The normal area do not take up iodine and do not show mahogany brown stain. The vessels are dilated. The first change in precancerous lesion is seen in punctuation. Thereafter, abnormal mosaic appear followed by white lesion. Lastly, atypical cells make their appearance. Keratosis is visible on naked eye examination. Low-grade squamous intraepithelial lesion shows smooth surface, irregular outer border, mild white change which disappear quickly. Fine punctuation and mosaic are present. SIL has sharp border, dense white lesion, post punctuation, irregular mosaic, atypical vessel. Endocervical curettage is required if the squamocolumnar junction is not entirely visible during pregnancy. Intense white appearance with post mosaic may be present, but the vessels are normal. One should not use endocervical brush because it can cause premature rupture of membrane and bleeding may ensue. Use instead wet cotton tipped application for endocervical tissue. Colposcopy can avoid unnecessary biopsy if the findings are normal. Avoid cone biopsy. Select the appropriate site of biopsy. Reduce the size of biopsy and conization. Therapeutic application of colposcopy. Colposcopic ablative techniques have been successfully employed in pre-invasive cancer of the cervix and vagina. The details are mentioned in the chapter of the cancer cervix. Colposcopy should be preferably restricted to first trimester pregnancy, as it can cause bleeding besides causing discomfort once fetal head enter the pelvis. Colposcopy of the vagina is indicated in the following condition: to evaluate vagina with abnormal pap smear but normal colposcopic finding of the cervix, rule out extension of CIN, women with HPV viral infection because lesion present, follow up of hysterectomy and conservative therapy performed for CIN disease. Because of multifocal lesion, wide vaginal wall and viewing at an angle of colposcopic examination of the vagina is difficult. Use levels iodine to identify abnormal epithelium. Colposcopy of the vulva is not always informative because of keratinization and deep-seated vessel and multiple lesions. Toluidine blue shows heavy staining but does not give clue to the underlying pathology. Biopsy is required. Colpomicroscopy. Unlike colposcopy, which looks at the tissue pattern, colpomicroscopy look at the structure at the cellular level. The magnification is 100 to 300 times. Interpretation is not very easy, hence lack popularity. Confocal microscopy. Endomicroscopy studies the depth of the tissue up to the dermis and recently employed as an adjuvant to colposcopy. Application of colposcopy in clinical practice. Extragenital endoscopy. Endoscopy examination of the other pelvic fissure of the interest to the gynecologist include the urethra, urinary bladder, anal canal, rectum, sigmoid colon. Seeking this information is useful in gynecological malignancy. Genital fissures, stress urinary incontinence, in case of development and memory such as the presence of double ureter and or ectopic ureter. Preoperative ureteric catheterization is gynecological malignancy or difficult operation involving large fibroids, broad ligament pathology, advanced endometriosis, and anticipating tense pelvic erection and disturbance plan safeguard against accidental ureteric injury. Teaming up with a urologist and pathologist can be mutually beneficial when treating a high-risk patient suffering from advanced pelvic pathology. Colposcopy. When laparoscopy and ultrasound had not developed, colposcopy enjoyed the privilege of diagnostic and therapeutic procedure. It was used to visualize pelvic organ and test potential fallopian tube. Therapeutically, it was performed for tubal sterilization and removal of ectopic pregnancy and adnexal mass. Once the laparoscope came into use, colposcopy looked at back seat and was abundant with certain limitation and contraindication to laparoscopy. Being understood, colposcopy is now occasionally employed. Obviously, pelvic and abdominal aspiration contraindicated laparoscopy. It requires only 2 cm incision and posterior fornix, so trocar is not needed. Colposcopy for 2 8 mm in size contraindicates pelvic adhesion or filtration of the pouch of Douglas on pelvic endometriosis suspected vaginal infection. So we finished this topic. In this chapter, only 3 topics are important: colposcopy, and endoscopy, in which laparoscopy and hysteroscopy is there. Okay. Laparoscopy. These are important. These 3 important topics in this chapter. Now I'm signing out from this topic. Thank you.